I had the pleasure to chair a session focused on immunotherapy of adults with acute lymphoblastic leukemia. This is a very exciting field of investigation nowadays because while several years ago allogeneic transplant was the only tool for immunotherapy, now we have several drugs and also CAR T cells that we expect to improve the outcome of our patients. So first part of the session was focused on Blinatumomab, which is bispecific T-cell enhancer. It enhances T-cells in fight against B-lymphoblasts by linking CD19 and CD3 on one and second part. It was proved to be effective in eradicating minimal residual disease in a clinical trial, and quite recently we have a publication in New England Journal of Medicine demonstrating that in relapsed refractory setting the use of Blinatumomab is associated with improved overall survival compared to the standard of care. So now we are thinking how to incorporate Blinatumomab in first-line treatment, but I think it's still a future. The second part was focused on CAR T cells. This is a kind of cellular immunotherapy, extremely exciting, with very high rates of complete remissions among relapsed refractory patients, up to 80%, and a lot of them appears persisting. So CR duration is expected to be quite long, and the cure rate as well. Then we discussed the role of allogenic transplantation in view of these novel components of our therapy, and in particular we asked the question whether patients who are MRD negative are still candidates for allotransplants. There were two perspectives. Professor Rivera argued against allotransplant in this setting, while Professor Steljes was in favor of allotransplanting. We had a voting, and in fact some of delegates who initially were in favor of transplants were convinced by Professor Rivera. But we are in a transplant meeting, so after all the majority still wants to transplant these patients, but it's really unclear in view of several recent publications. Finally, I presented data from the EBMT survey on the trends in the use of allogenic transplants in the European countries starting from year 2000 up to 2012, and I demonstrated a continuous increase for both matched sibling and unrelated transplants, but the increase in case of unrelated transplant is much more pronounced compared to matched sibling. In recent years, we observe a sharp increase in haploidentical transplants. This is thanks to new immunosuppressive protocols, especially the use of post-transplant cyclophosphamide to prevent graft-versus-host disease. And the last remark, in parallel with an increasing number, we also observe improving results of allogenic transplants, once again for both matched sibling and unrelated donor transplants, mainly due to reduced risk of non-relapse mortality. So I believe there is still a big role of allogenic HSCT in a setting of adults with acute lymphoblastic leukemia, but probably in future we will combine this with novel immunotherapeutic strategies, allowing higher proportion of patients be cured.